Hello, everyone, and welcome to our education session for this afternoon on the management of anemia before colorectal cancer treatment. It's brilliant to have you with us this afternoon. And before we get stuck in and I introduce our brilliant speaker for the afternoon, there's just a few little bits of housekeeping I'm going to rattle through. So first up, I just want to say thanks to Amgen Limited. So Amgen have provided a restricted donation to support this virtual event. They've had no input into the agenda or the content, but thanks to them, we're able to bring this event to you all for free. So big thanks to them. Along the bottom of your screen, hopefully, you will see the chat function, a little speech bubble. If you click on that, a speech box will appear, which you can move around. That's where you're perfectly welcome to say hello to everybody. We've got members of the Bowel Cancer UK team in that box, sort of dropping messages in. We'll also be signposting to any resources that get mentioned during the course of the session. Anything that goes in the chat doesn't appear on the recording, so you're welcome to introduce yourselves, say hi. I can see lots of people already saying from. Use the chat box. A little bit further along from the chat box are two speech bubbles, and that's the Q&A function. So that's where we'd really love you to be putting your questions for our speaker. So if as you're listening, you think of anything you'd like him to expand on, pop your question in there. Please try really hard to put your questions in there and not the chat box, because I can't see them in the chat box. I only see them in the Q&A box. I think you've just had a prompt in the chat box to say that the session is being recorded. So we will send out the links at the end of the event to everybody so that you can either watch it again, share it with colleagues, and we'll also be putting access to it, putting it up on our website, so you'll be able to access it that way too. At the end of the session, there will be the usual evaluation form. So we will email around a link to the survey, and we'll also be popping that in the chat towards the end of the session too. It'd be really, really, really good if you could just take a few moments to fill out that evaluation form, because it's the feedback we get from you that not only means we can improve these events and make sure that we're bringing you exactly the type of content that you want in these events, and covering the subjects that you want us to cover, but it also means that we can then use it to ask funders for additional money to pay for us to be able to bring these events to you. So please fill out the evaluation form. So over to you. Going to get you to do a little bit of work now. I'd love to know at these events sort of who we've got, where you're joining us from, and how many people are watching. So our first poll question for you to take part in is, where are you joining us from? So if you wouldn't mind letting us know. Just give a few seconds before we share the results. Oh, okay, if we can share those results. It's just an all England showing today. I think this is our first time we've had nobody from Scotland, Wales and Northern Ireland joining us, which is a real shame, but welcome to the 40 of you who are joining us from England. We also would like to know how many people are watching, because we know that some of you, it might just be on your own, but some of you might be 3 or 4 people huddled around a computer. So again, if you can just let us know, that would be great. Fab, and if we can share the results of that. Brilliant. So we can see we've got lots of people watching on their own, but then a fair few people in 2s and 3s, which is great. So thank you, everybody, for taking part in those polls. There'll be a couple more polls coming up throughout the course of the event too. So that was just by way of getting you to practice. Right, enough from me. Let's move on with the main topic of the day. So it gives me huge pleasure to introduce you to our speaker today. Our speaker is Dr. Ravi Rao Baikady, and Ravi is a consultant in Anaesthesia and Peri-operative Medicine at the Royal Marsden NHS Foundation Trust. Ravi, hello. Did I pronounce your surname correctly? Because we've been wondering how to say it.
Perfect.
Perfect, brilliant, thank you. Well, lovely for you to welcome you to this event, and thank you for carving out an hour to come and run this session for us. So without further ado, I'm going to hand over to you, and your slides will appear.
Okay, Thank you very much. It's wonderful, and thank you for the invite, Haley, you, and of course Philippe. I think he's also on the line somewhere.
He is,
So
yes.
yes, thank you. It's wonderful to connect to you. But I always enjoy teaching our nursing colleagues and also paramedics and the transfusion team and everything. So it's
Brilliant.
irony. It's irony that I'm in the middle of a liver list, which is colorectal metastasis.
Well, there you go. There you go. And we're just asking a question we're just asking the people who are watching how confident they are in their knowledge
Excellent.
and understanding of anemia management. Looking at this, so ranging from not at all confident all the way up to, I assume, supremely confident. You've got a very mixed bag, so you've got your work cut out for you this afternoon.
That's
Ravi.
good. I'm looking at all those things. I think it's up and down the country. I was in Liverpool over the weekend. It's a similar situation, so it's good that there is a noise around
Brilliant.
anemia. Yeah. Can I start? I think I got the control now. Is that correct?
Yep.
Yes.
And I will hand over to you.
Yeah. Thank you very much, guys. As the host introduced me, Catherine introduced me as a consultant anesthetist, and I think a lot of people around anemia, hemorrhage know me for a while because I've been in this field for about last 17 years. These are my conflict of interest, nothing directly for this educational meeting, but these are all for educations only. So as I was introduced, I work in Royal Marsden Hospital. This is the world's first hospital to care and research or study cancer. So since 1852, it's been there. And this is our main building, which is in Chelsea, in Bang in central London, where we do majority of the major cancer work, major cancer surgical work. And we also have another site 10 miles down south in Sutton, which is predominantly oncology and pediatrics and hemato-oncology, plus some theater work, but nothing major. So it's a twin site, probably around 200, 300 files. Oh, here we go. Right. And so what I'm going to run through, not just for the colorectal, in general for the cancer, because it's difficult to isolate just colorectal cancer as one group because it's all mixed bag with the metastasis, with a few other cancers. So in general about cancer, pathophysiology, how to diagnose, especially the iron deficiency anemia, which is the commonest one, and options for management, how do you, and also the dynamic approach, because all along the surgery was the main focus, but I'm going to try and explain to you how it should be dynamic approach. And you as the nurses and the CNSs nurses are the key part of this anemia pathway, and also the current and ongoing future research. If anybody wants to attend any of this meeting, because I've been involved with this bleeding clotting hemorrhage for the last 18 years with the Association of Anaesthetists in UK. So our next meeting in the Royal Society of Medicine on 24th of London, you're always welcome. It's not just for the doctors or the anaesthetists, it's for the transfusion team and the nurses and ODPs and everybody. So what are we talking about? And I think this is one of the basic exercise I do with some of the nurses and the junior doctors when they come in my theater session or my clinic, which is basically we breathe in oxygen, air, which is called oxygen, which is important for every cell. How this oxygen is carried in the body, because every cell in the body needs oxygen, which relies on a pumping mechanism, which is your heart, and an exchange mechanism, which is your lung. But who carries oxygen is your good old friend, hemoglobin. And within the hemoglobin, in the center of the hemoglobin, you have this ion, which carries oxygen. So if you do not have enough hemoglobin, doesn't matter how good is your heart or lung, you're going to struggle, number one. Number two, all these systems are interrelated because they depend on one on each other. So, for example, if you start bleeding on a young fit patient and suddenly heart says, okay, beat faster. So instead of heart rate of 60, 70, it will go to 100. At the same time, this patient start breathing heavily because patient realizes that's because there is a bleeding. So I need more oxygen, so breathing heavily. That's okay in a young patient or a young obstetric patient, they can tolerate and up to a certain amount of bleeding. But imagine you are average 70 plus man or woman with cancer, bleeding, hemoglobin 70, 80, 90, with atrial fibrillation, with the history of smoking. So the compensatory mechanism is very minimal, and that means there is very poor reserve. So that put more focus on not only your heart and lung, you need to optimize your hemoglobin if you are not well. All along, people thought hemoglobin definition, male, female differentiation, 120, 130. So that's all gone now. So is anybody less than 130 is by definition, male or female, is by definition anemic. Within that, you can differentiate mild, moderate, severe. If it is less than 80, you call it severe anemia. And then, as you know, the commonest cause of anemia is iron deficiency. And within that, I'll explain a bit more later. True as a functional deficiency. And also, it's not just about iron, and there is vitamin B12 and folate also play a key role. Why I put this is because if you rule out the iron and vitamin deficiency, if the patient is still anemic, and then you need an expert opinion why this patient is anemic, that's when you contact a hematologist or a specialist or a kidney specialist if it is a patient that has a renal failure. So here we go. Is there any other problem going on? Because iron is normal, vitamin is normal, and patient is anemic. What's going on? And you have all these guidelines. I call it forest of guidelines. Sometimes we are bombarded with these guidelines, national guidelines, local guidelines, international guidelines. So in terms of the guidelines on transfusion, anemia, hemorrhage, since 2015, all the guidelines have changed. It doesn't matter which organization you look for. But the good news is most of them say the same thing. So I don't know whether you can see in this slide at the bottom, I noted down one key factor is do not transfuse in a non-bleeding patient unless the hemoglobin is below 70 or below 80 if the patient has a symptomatic ischemic heart disease. That means patient has an angina or a known coronary artery disease with symptoms. Other than that, if the patient is a non-bleeding patient, if the hemoglobin is less than 7, unless it's less than 70, you should not do blood transfusion. Okay, that's one. The second thing is the problem with these guidelines is they don't tell you how to implement. Okay, so what to do next, how to implement this. So regarding whether it's iron treatment or vitamin treatment, or anything else, they do all the recommendations, but they don't. And this is where the problem is, because yes, we do have guidelines. We know what to do. The guideline tells you, but how to implement in the NHS service or private sector or anywhere or in the GP service. That's where people struggle. That's why this has been making a lot of noise, but people don't know how to implement. So I'm going to touch base on this a bit later, how we implemented, I'm sure, and a few other trusts, and one in King's Lynn and one in Cornwall, they all done it very well. And I also think we need to use those examples. We also have a peri-operative guidelines that just released a few weeks ago in the Royal College of Anaesthetists peri-operative division. Again, it gives you the 7 points. So how to identify and how to engage the patient, identify the cause, use the test, options of treatment, communications between the various teams. So that's a key, because often they leave it to the anesthetist just before surgery. It's too late. So it has to happen at the diagnosis of disease oncology or anything else, or in the surgical clinic or in the oncology clinic or in the GP. But when it comes to leave it to somebody to do it just before operation, it's not going to work. And also you must discuss all these issues with the patients. And not only this Royal College definition, the guidelines come out recently, and also there is recently the global definition of what we call the patient blood management, which some of you may remember, originated in Australia in 2005 or 4, and now it's most countries adopt this. Even the WHO recommends this strongly, and there's a global statement on this, and I think put the patient at the center. And then evidence-based approach to, and also whatever you do, it should be the patient outcome should be the main focus. not just a correction of anemia in one part, one segment of patient journey. It should be the throughout the and also, as you can see in the graph there, and increasingly hospitals are adapting this, the countries and the hospitals. So as I said, the guidelines say avoid transfusion and treat the patients with anemia because of various diagnoses, and we all know the limitations of oral iron. The problem is how to implement these guidelines unless you have the resources in place, and also more importantly, education is not going to work. Yes, I always say when you implement anything, you always rely on the 3 E's of basic fundamentals of medical practice, which is first one, you look for the evidence, whether it's your local evidence or whether it's a research or whether it's your audit or whether it's your QI project. And then you look at the economics. Is it worthwhile? Because no point just because some small research suggests that expensive drug to be used, but it's not going to be economical, and then no point implementing that. So there has to be strong evidence. Then it has to be, you can't mess the economics. And then you need to do the ethical practice. That's very important for the doctors and the nurses. So do we appreciate how common it is in cancer, and possibly most oncologists themselves are not aware of this, how bad it is, because some of these cancers, up to 60, 70, 80, 90% of the patients are anemic. So most cancers at diagnosis, if you take the average, it's around 40% of the cancers at diagnosis are anemic, number one. Number two, you add a treatment, which is chemo or radiotherapy, it will become probably 60%. Then you add an operation, which is a major operation, and some of them come from multiple minor major operations. So it will become probably 90% of these patients are anemic. Okay, whatever may be the cause, which I'll come to that in a minute. We come to specific cancer because what I'm going to talk to you is mainly on the left-hand side, which is a solid tumors. I'm not going to talk about hematological malignancies because it's a completely different kettle of fish, which is hemolysis or bone marrow issues or to do with the platelets and other factors. What I'm talking about is, so look at this on the left-hand side, the GI cancers, and then the colorectal cancers is the commonest group. Having either iron deficiency anemia or a type of anemia. Coming to the cause of cancer, on the left-hand side, it says that cancer is one of the commonest cancers in blood loss, because that itself will be the presenting symptoms, whether it's a colorectal or upper GI cancers or even gynecological cancers. And then at the same time, as you start treatment, at the bottom here, you can see the nutritional issues. And then on the right-hand side, when you start the inflammation sets in because of your treatment or your cancer itself, which in turn causes increased hepcidin, which is on the in the picture I had shown in the liver, but the liver produces a hormone called hepcidin, which blocks iron absorption from the duodenum. So that can cause functional iron deficiency. Then you have on the right-hand side, you have the bone marrow effects, either due to the cancer or the treatment or combination, bone marrow suppression, and then we'll have some people call it anemia of chronic disease. Then you have the kidney issues or hemolysis. So there are a multitude of causes for a cancer patient to develop anemia. At various points of the cancer journey, there may be the cause may be different, but all it leads to the commonest type will be iron deficiency. So why it is important? Because if so what if the hemoglobin patient has cancer, that's got a patient got anemia. So what is got to do with the cancer, they might ask? Because if you do have anemia when you have a cancer, your prognosis is bad. Okay, we have enough data to suggest that whether it's with or without blood transfusion, probably if we have the blood transfusion, it makes it even worse, the prognosis of cancer. And again, there are some studies have shown that even in operation, if you do the operation when the patient is anemic, they're not going to do well. We have enough data on the breast cancer surgery. We have data on the chemotherapy. If you have a chemotherapy patient with who are already anemic, they're not going to do well in terms of chemo response, in terms of recurrence, if they've been tolerating chemotherapy, and or on further surgery. So patients are absolutely, some of these symptoms are confused. People think it could be chemo-induced. Actually, if you take a careful history, patient is already anemic, exhausted, fatigued, and very tired, and you add chemotherapy, then people think it's chemo is causing all these things. Probably it's either anemia is causing these symptoms or a combination of chemo and anemia. Again, same thing goes with the radiotherapy. In fact, some of the radiotherapists don't even treat the patient if the patient is really anemic. Remember, transfusion is not the answer. It may be a temporary solution, but it's not the answer to correct anemia. If you look at the transfusion, and if you solid tumors and transfusion risk of recurrence, you can see that even in colorectal, it's the highest number of recurrence if your patient had a transfusion during their cancer therapy. Again, because that's one of the hypotheses is to do with the immune function, because the lower the immune function, more the metastasis of cancer. We have both animal and human data to suggest that your prognosis of not just a colorectal is proved in lung cancer, breast cancer, and prostate cancer. That there is enough studies to show that. Coming to the, and this is way back in 10, 20 years ago, even the oncologists published this, okay, iron deficiency in cancer. On the left-hand side, absolute deficiency. That means you have low hepcidin, ferritin less than 100, and T transferrin saturation. That's all you need to know, transferrin saturation, because hepcidin is not part of the routine blood test, whereas a ferritin and transferrin saturation, if you write down in the biochemistry form, cost less than 5 pounds, and it's cheap test. It will tell you, and I think it's at the diagnosis of cancer, you do this test, and then you know the patient, where the patient lies. And functional one, and it's where, because of the high hepcidin, where it's a ferritin can be high, but transferrin saturation is less than 20%. That means patients have enough storage of iron, but it's not coming out because of the inflammatory process. So the circulating iron levels are very low. So this is just to show that, make you understand, ferritin is your stored iron, and transferrin is the transport, and bone marrow is your petrol station where you go for, where bone marrow produces millions of red cells every day. On the lower half of this slide, which show you when it's normal, then you say that the ferritin actually, the normal levels are 100 to 800. Your lab says 20 is normal, and that's wrong, because unfortunately the lab corrections are not made in the last 50 years or so. So the normal ferritin levels are more than 100 to probably up to 800. If you see above 800, then you need to be worried. Until 800, it's fine. Even the saturation, normal transferrin saturation is 25 to 45%. Okay, if you feel absolutely normal. That's why they're below 20% and the iron deficiency. So look at the right-hand side of the screen. By the time the iron deficiency happens, you're already very low in your hemoglobin, and you are low at the bottom. Another phenomenon we're seeing increasingly is patients with a normal hemoglobin but having a pure iron deficiency, which is common in women. You might say your patient has iron, Ravi, just let's treat with some oral iron. The problem is, it's poorly tolerated because of the side effects. Number two, it takes, even if you're tolerating well, if you're absorbing well, it takes months and months to see a small change. Okay. That's number two. And number three, I always say this, if you have a good diet and if you still have iron deficiency, I don't think a tablet is not going to do well. That means you're not absorbing iron very well due to either inflammatory process or genetically you're a poor absorber. And we've seen them in a lot of young women with amenorrhea. For some reason, they're just not able to increase the iron absorption. Doesn't matter how good the diet is or how much tablets they're taking. All along, people thought giving the 3 tablets a day of iron was good, but up until this Swedish studies showed us a few years ago, actually, if you put too much iron in your gut, and it in turn produces, gives a signal to the liver to produce high hepcidin, which blocks the iron absorption. So actually giving 3 tablets a day is wrong. Even daily iron once a day is also probably not good. So to start with, the iron supplement should be alternate day on an empty stomach with some vitamin C or some orange juice or lemon juice in the morning. It's the best way. That's number one. The another myth is people drinking caffeine straight after meal, which is wrong because caffeine prevents iron absorption. So you need to advise these to the patients. Good diet, whether it's vegetarian or, because remember, non-vegetarian diet, which has got a natural heme, which is 40% bioavailability or absorption, whereas vegetarian vegan, it's only what we call non-heme iron is only 7% absorption. So vegetarians are more prone to iron deficiency anemia. That doesn't mean that you should start eating non-veg straight away, but just to caution, that is the good diet can still help you to prevent iron deficiency. This is our going to the Marsden setup. Over the years, we developed the service. We appointed an anemia nurse in 2020, beginning just before COVID. We aim to do pre-op service 2 to 3 weeks, 6 weeks before surgery. And what happened with the COVID is we had an anemia nurse, so we have a part-time fellow, but we couldn't get the patient pre-op because of the COVID. So what we started is a unique post-operative anemia ward rounds, daily ward round. After this lecture, I had to do my own ward round here, going through the list of patients who are in the ward post-surgery. We do IV iron infusions and vitamins if needed at the time of discharge. So either day before discharge or on the day of discharge. And we have a huge data of probably 2,000 patients now, and we're going to publish that and showed it's safe and it works very well. So of course, we're doing the audits and quality improvement projects on that. This is our pre-assessment service. Once we try to do the one-stop clinic, they come in the morning, they have the blood test, they have the anesthetic assessment, they have the exercise test. By the time they all finish all these things, their blood test results come back, and we know if they're anemic or iron deficient. If we already don't know, and we try to arrange the iron infusions on the same day, or the vitamin supplements, they take it while they're walking out of the door. These 2 iron preparations we use. The good news about these preparations is you can do nowadays total dose infusion, where the Monofert, though we can give up to 2 grams, we do maximum 1600 milligram. Anybody above 80 kilos, you don't need more than 1600 milligrams of infusion over 30 to 45 minutes. Whereas Fer-Inject maximum in one infusion you can administer is 1 gram. So if the patient needs more than that, you need to bring them back after a week or so. But in general, probably average patients up to 60 kilos, I always say 15 to 20 milligram per kilogram is fine. And if the patient has normal hemoglobin but severe iron deficiency, we do half dose, which is 10 milligram per kilogram per unit. As you know, that there are strong indications for intravenous iron, and then some of these other indications though in cancer there are strong indication, but some cancers there is still the question mark whether it should be given with erythropoietin or the timing, and these are still a research field. The same thing for the heavy menstruation as well. The timing of the iron is in question rather than whether they need iron or not. So just going to run through quickly to our service in 2020, 728 iron infusions. As you can see, it's female or common in the sense more than 60%. Even if you take out breast and gynae cancers, still female cancers have the high incidence of iron deficiency anemia, or anemia in general. As you can see, majority are general surgical, which include some of the HPV and colorectal cancers as well. Gastroenterology means mainly the upper GI ones, and then we have various other groups and oncology as well. So during the COVID year, we had a majority had post-operative iron infusion through our ward round, and we adhere to our guideline depending on the ferritin and transferrin saturation. And HbA HB increments. I think I always say this, probably if you give it around 4 to 6 weeks, you will see anywhere between 1.5 to 3 gram, that is 15 to 30 gram rise in hemoglobin. This is just to show that what happened in 2019, comparative figures. I can just to highlight you, one in the gray, that is a pre-op iron, and one in the yellow is a post-op iron. Probably after about 8 to 10 weeks after the iron infusion, doesn't matter, they all they show the same thing, same results. But I think post-op iron, and people keep asking what's the relevance. Relevance is probably 60–70% of the cancer patients after surgery, they need to come back for their further oncological therapy. That we call it RIOT, return to integrated oncological therapy. The standard is in certain cancers is 12 weeks or 8 weeks. So what we are trying to do is, can we reduce that to 4 to 6 weeks so that they can get back to, the key is anemia correction is key for return to oncological therapy. So that's what we are trying to prove and trying to achieve. Just to show some case studies, what happened in one of the gynae patients. I have loads of colorectal studies as well, which showed similar results. Giving a total dose iron infusion, and they came with hemoglobin of 83. And then within a couple of weeks, it's gone up to 106. And then he had the diagnostic surgery, and then they came back and had a further operation and chemotherapy. Same thing with the sarcoma patients as well. Same thing again, if the patient is really low, give the blood transfusion, and then you can bring them back for the IV iron after a few days, and hemoglobin up again. And then patient had a major surgery, didn't lose much blood, and did not need any transfusion, and hemoglobin at discharge was 112. And again, in 2021, we continued that practice, and just to highlight, saying that it's a post-op iron has a quicker recovery, one in the blue, compared to a patient who had a pre-op iron at 4 to 6 weeks time. So that's important for the return to oncological therapy. In fact, way back in 2015, our own small trial showed that one in the dotted line is the one which had the post-op intravenous iron. Surgeons took it to their own hands. Anybody less than hemoglobin 100, that used to be the case at that time, they saw it as anemia, and they treated them and with the IV iron. Whereas one at the top, they did not get any iron because their hemoglobin was near normal pre-op, and they didn't lose much blood, and the hemoglobin was 100, 110 immediate post-op. And look at that. So they take a little longer to recover. Probably at about 8 to 10 weeks, they're all doesn't matter. But because the problem here is, if you want the patient to come back to treatment quickly, like 4 weeks or 6 weeks, you need to treat them so that with the post-op iron, it has a benefits. This is our own data showing in the similar results in our gynecological patients as well. People keep asking me side effects of, yes, and with the modern preparations, severe hypersensitivity reactions are extremely rare. We had few, and we had a few, 2 or 3 cases, which I haven't mentioned here, of partial extravasation and staining. So you need to be, it's very important for the nursing team to get trained in iron infusion. It's important to flush the cannula and make sure that there is no extravasation. If you have a staining, though sometimes it disappears on its own after a few months, but some can be for the lifelong stain, so or even a few years it might stain. So that's why you have to be very careful with that. Is there any contraindications for iron in cancer? Absolutely no contraindication. Look at any whether it's a colorectal or the colon cancers or breast cancers. These are some of the common cancers they looked at. There's no evidence that giving intravenous iron or the oral iron has any influence on the cancer outcome. Now, look at the evidence. What I've done is I put some of your own colorectal data. So looking at, this is from the World Journal of Gastroenterology, the pragmatic approach to treatment. Okay, of course, these guys still suggest oral iron. I suspect you will be extremely rare to find some patients who tolerate oral iron, or you have time to wait for that, because oral iron takes months to work. So you don't have that much time in treating the cancer. So to wait for the cancer to treat. So I think oral iron has a very, very limited role to play. But once you treat with the intravenous iron, for maintenance, you can suggest oral iron a few weeks after the intravenous infusion. So this is some guidelines. And this is one of the trials showing, one of the, it's recently 2 years ago published, looking at the post-operative at discharge colorectal cancer surgery and the incidence of anemia, as you can see here, and pre-op anemia again. The one in the blue is women and one in the red is men. So I got 10 minutes, I'll finish the 5 minutes, I'll finish this. So just to highlight is how common it is, and again, is common in women. Pre-operative inflammation and correcting prior to surgery in colorectal cancer. Again, the same thing. There's a pathways there to, if you want to how the inflammation affects on absorption. And again, some people still suggest oral iron, but I think it has got a very limited role to play in cancer journey. There are some single center cancer trials suggesting it works and in hemoglobin correction. And there are some more trials. Again, the problem with some of these trials are single center or the small number of population. So we don't have a large randomized trial to showing that it makes a big difference. But these single center trials giving a strong hint that it reduces transfusion, some of them, it reduces length of stay, correction is good, return to oncological therapy is better, and functional outcome. That's why I think fatigue score or a functional outcome, that's the key. And it sometimes is difficult to establish, but whereas a colorectal is a unique group and it's, you have a set pathway, and it's very, very good to identify functional outcome in colorectal surgery. I don't want to go too much controversies about the PREVENT, our own PREVENT trial. I was co-author, and we recruited a maximum number of patients in Marsden. What it showed, the PREVENT trial, is because what happened during the PREVENT trial is nice guidance came, transfusion thresholds changed, and we had massive surgeries. It didn't show, the outcome was, questioned was transfusion. It didn't show any difference. One of the problems we had was intravenous iron was given only 2 weeks before surgery. So as you can see here, hemoglobin optimization was better if you had the pre-op iron and quicker. And number one, number two, there's some hint that readmission rates are less if you have the intravenous iron. Here is just to show how long it takes to give anemia correction. Actually, probably if you wait for 6 to 8 weeks, your hemoglobin correction is anywhere from 14 to 16. This is one of those hip fracture trial which showed that. So here we go. So I think you need to give enough time, probably 6 to 8 weeks. And also the importance of erythropoietin in oncological therapy with anemia. And again, if you do give erythropoietin, you can give, it should be administered with intravenous iron for better effects. So yeah, so I think, but in cancer surgery, it's still not indicated because of the increased incidence of DVT. So either side of 4 weeks before surgery or after surgery, avoid erythropoietin. Otherwise, if you have a anemia which is not responding to many treatments, so consider erythropoietin. Again, often forgotten in anemia practice is the iatrogenic anemia. Please do not request unnecessary blood tests. So because that contributes to the anemia, number one. Number two, it's our own fault, the doctors and nurses. If the patient is sicker or anemic and we request more blood tests, and so we're drawing more blood. So you have to be mindful. You should use pediatric tubes. You should do routine blood gas analysis will tell you more, which requires only small 0.5 ml of blood, which give you lots of information. You don't need a lab test. So be mindful of unnecessary blood test request. Again, this is the last couple of slides. It's iron and cancer, what's coming up. So ferroptosis is, I think it's a lot of cancer nowadays treated with the immunotherapy. So the cancer cell death, ferroptosis is the key. And for ferroptosis to happen, the enzymes rely on iron. So what we are trying to establish, is there a difference between iron deficiency and no iron deficiency, whether it makes a difference, something we're going to research on. So in summary, anemia in cancer is very common, all the way up to 90% of the patients, 40 to 90%, multifactorial, easy to diagnose and treat, simple blood test. Transfusion is only for active bleeding, and IV iron is simple and effective, which is common. And also, please remember, all anemias are not iron deficiency, corrective vitamins, or is there any other cause you need to identify. So we're trying to do some trials on post-operative iron as well, whether it makes any difference in terms of riot or functional outcome or readmissions after surgery. Of course, HB optimization and blood transfusion. Remember, there's an alert today on there is a blood levels, the stocks are less, so it more emphasis on avoiding unnecessary blood transfusion. Of course, we are trying to educate our oncologists to get the anemia treatment established during the treatment rather than just during the surgery. It should be throughout the patient's journey in cancer. Of course, importance of iron in immunotherapy, and also do not forget to give erythropoietin, and also patient is on active bleed, do not forget the role of tranexamic acid. Thank you very much. I'll stop that. Sorry, I might overrun, so it's okay. We can still
expertly timed. Expertly timed. Well done. That's no mean feat. I think you might have had a record number of slides as well. So, so whistling through. We have got some really good questions though, so I'll jump straight in. We've had a few people ask about a point you made quite early on around transfusion causing a higher risk of recurrent disease.
Yeah.
So why is that?
I think it's to do with the, I think it's a metastasis spread with the, it's to do with the immune effect of the transfusion itself. If there's a blood transfusion triggers, that's interleukins and other things. So, because remember, in the colorectal cancer, and it's a majority of the cancers, already metastasis is happening, micrometastasis, and you add a transfusion, which might trigger the more immune reaction, and then the cancer cells spreading. So that's correlation data which is published, and there is no detailed study on why exactly it happens, but it should probably is to do with the immune reaction to the transfusion itself.
It's quite a staggering statistic, wasn't it?
Yes.
Kind of, yeah.
But at the same time, these studies are all on the single tumor cells, so tumor types. It's a majority on lung and prostate and other things. So there are a few on the colorectal as well. But I think they all say the same thing.
Yeah.
So if you have a cancer, if you have a transfusion, the outcome is not good.
Not great. Thank you for answering that. Okay, complicated one coming up. So in view of the benefits of iron transfusion and post-op outcomes, less blood transfusion usage, etc., do you think that in the future all cancer patients should be having an elective iron transfusion, even if their levels are normal?
Not with the levels of normal. I think it's a good question, because what we do nowadays is, irrespective of whether they're anemic or not, don't wait for the anemia to be established. We get the baseline iron studies in the pre-op, or we encourage surgeons to do it. Okay, I don't mind whether they are. So then when the surgery happens, if they become anemic after surgery, but I already have the baseline iron studies, if they are low, I know that this patient will get benefits because iron levels are already low, though they may not be anemic, but the iron levels of borderline are low. And then the moment you lose 1 unit of blood, and then by definition, they become iron deficiency. Remember, 60% of your iron is in the hemoglobin. Okay, so if you lose 1 unit of blood, which most patients do when they have a surgery, okay, or if you stay in intensive care for a couple of weeks, you lose more than 1 unit of blood just by simple blood tests.
Gosh.
So,
when you say it like that to somebody who doesn't work in clinical setting, that's a lot, isn't it?
Yes, that is a lot. Yeah.
As somebody who has given blood today as well.
Yeah.
I know. Another question, Ravi, is do the patients need to stop oral iron if they are to have an infusion? I think this is a query to do with if a GP has already started a patient on tablets.
Yeah, I think what we suggest is the day before stopping is fine, or even if they've taken it, that's fine. But once you've done the infusion, up to 6 weeks, do not take oral iron. Okay, and then you do the repeat blood test after 6 weeks to see the iron levels and hemoglobin, like what's the response is after 6 weeks. But after 6 weeks, you can restart oral tablet to maintain, because some of these patients, if they continue to bleed or further treatment, they're going to back to square one again in a few weeks time. So they become anemic again. So to prevent that, and you start the oral iron maintenance so that to maintain the level of iron, try to with the oral iron rather than coming back for another iron infusion. That's the advice we give.
Brilliant. Great. Thank you. And somebody said they think that you said this, but they missed it. What is the maximum infusion of Monifer? I think Monifer,
yeah, Monifer,
is that right?
Yeah.
In one transfusion pre-op in an averaged weight patient of 70 kilos.
Yeah, up to 20 milligram per kilogram, up to 1600. That is 80 kilos. If it is 80 kilos, if it is 70 kilos, 1400. But patients above 80 kilos, we will not give anything more than 1600. That's enough. I think I know the pharmaceutical industry says you can give up to 2 grams, but I don't think we need to waste on more than 1600. So
brilliant. Thank you. Well, Ravi, you'll be pleased to know that's the end of the questions. We do have a couple of polls that we just want to keep you on the line for.
No problem.
And there might be some last minute questions come in, you never know.
Yeah, no problem.
But I think our first poll question for our audience is around anemia pathways.
Yeah.
I'll just wait for the team to right, yes. So we're asking whether or not you have access to an anemia pathway at your hospital.
Yeah, that's a good question.
Brilliant. If we can share those results. So we've got a split between the yeses and the nos, and quite a lot of people don't know. In fact, nearly half of people don't know. So I guess that's a first thing to do after this, isn't it? Is go away and find out.
Yeah.
Brilliant. And then the second question is the follow-up confidence question to see whether or not your epic slide deck and expert view has shifted people's confidence.
Okay.
So let's have a go. Oh, way more sixes. Way more people are. Yeah. Brilliant. If we can share those, that would be great. So yes, I think we can see that the message you've had to deliver has been well received and has clearly been has answered some of the questions that people had.
Yeah. Okay.
So Ravi, that's brilliant. Thank you so much for giving us your time this afternoon. So on behalf of everybody watching, I just want to say a huge thank you to you.
Thank you. Yeah, thank you.
And then before our audience disappear, I've just got a couple of slides to run through, which is just promoting some of our patient-facing services here at Bowel Cancer UK. I'll wait for them to pop up. Okay. So first up, just a plug for our online communities. So we have a forum and a number of specialist Facebook groups for patients. So we have Facebook groups for living with stage 4, caregivers, those on immunotherapy, and our new pelvic exenteration support group. So head to our website, direct your patients to our website. The forum has its own tab where and it's just incredibly supportive. Patients can go on, have a read of what lots of other people have asked and the answers that the community have given, or you can actually sign up and then you're able to ask a question. So that's a really great resource for you to promote with your patients. We have a patient education event coming up in a couple of weeks on living well with a stoma. So we've got Melissa Holland, who's a lead stoma CNS from Lewisham and Greenwich Trust, is giving us an overview, or giving patients an overview and an introduction to stomas and guidance on managing any problems. And then one of our volunteers, Win, who is he's an Elvis impersonator, so I'm desperately hoping that he's going to do a bit of a turn for us while he's sharing his personal experience of living with a stoma. So you might want to tune in for that Elvis and a stoma. What more could anybody want? And then just to say to all of you that if you've missed any of our previous education program sessions, you can catch up with them either by scanning the QR code here or heading over to our health professional area on our website. So that's where you can catch reruns of our previous sessions, including our annual education day, which we held a few weeks ago, one on pelvic exenteration surgery and one on genomics. In fact, 2 on genomics. It was a part 1 and a part 2. So head on over if you haven't seen those. We're busy putting our plans together for next year. We want to make sure that the content that we put on through these events is absolutely what you want to know about, and the sort of covering the topics that you're most interested in. So if you haven't already signed up to our NCCNN newsletter, you can do that via our website. You can also join the NCCNN Facebook group, and then you'll get our sort of lots of polls and things asking you what you'd like to see included next year, as well as through the evaluation form that you're all now going to fill out. And then if, well, we don't have anybody joining us from Scotland, but if anybody here wants to pop to Edinburgh and run a marathon, a half marathon, a 10K or a 5K for us, there's a brilliant festival of running takes place in Edinburgh every year. So we're just doing, our fundraising team have asked us to do an early plug for anyone interested in doing that. And for those of you who are fans of facial furniture and have the ability to grow a beard, if you'd like to do that to raise money for Bowel Cancer UK, then you can join the Decembeard team. And I guess it's as simple as it sounds. You grow a beard throughout all of December and people pay you money to do so. So again, head on over to the website if you want to know more about that. So I don't think there's anything left for me to say other than thank you all for joining us this afternoon. Thanks for taking an hour out of what I'm sure were very busy Wednesdays. The evaluation form, the link will be on its way round, so please do just spend a couple of minutes on those. And I think this is the last one of our education events for this year, and I don't really want to say the C word, so I'm going to wish everybody a very happy end to 2022 and see you all in 2023. Thanks for joining us. Take care.